Thank you, Corey. Thank you for the opportunity to present today. I appreciate all of you being here fighting the traffic. And we're going to spend a rather busy next 20 minutes talking about the challenges and benefits of lung cancer screening. I'd point out to you our biggest challenge is captured here on the first slide, because that is a synthetic nodule that is made so that it looks to be 6 millimeters in its longest axis. It's 45 millimeters cubed, and that's what we want to find the war on lung cancer. This is the smallest object that we think that we can measure a change in with a confidence interval that will allow us to see a difference in volume of 10%, which is remarkable, but possible today. And this is, some of you remember the world of Niles Martini and Bob Ginsberg when we used to be treating, regionally advanced 3B disease where we had much greater volumes of cancer. Well, our opportunity to cure cancer relates to earlier interventions, and we're going to be talking about how that happens. So first, we have to frame the public health context. I have no disclosures. We have learning objectives. We want to talk about where lung cancer is in terms of mortality reduction, how we can do this economically, what is the current status of implementation nationally now that the Centers for Medicaid and Medicare Services support the test in the target population. And then we want to talk about this emerging experiment of informed decision-making. So I'd like to explore what is the benefit of lung cancer screening in terms of mortality reduction. The NLST, which was a baseline round of screening with 2 annual screening follow-ups, suggested that mortality reduction benefit was on the order of 20% over that time window. The risk of lung cancer, as you all know, in people who have smoked for a long time lasts to their death, and we'll have a slide about that. And so there's a continuous development of lung cancer in that population. So a 2-year window is very important, but those people live for decades. And so the aggregate benefit may be, and there's been other modeling efforts, some from LCAP, in which they think the mortality reduction benefit over time would be more on the order of 36 to 64% compared to a couple of reference cohort studies. And then from CISNET, from the group down in Houston, there was a suggestion that if you looked at the LCAP and you modeled all the other various influences, you might have an aggregate survival benefit on the order of 46%. Now, it's still, lots of modeling going on, but the aggregate benefit of lung cancer screening over the remaining life of people at risk for lung cancer is a significant number. So where are we in terms of lung cancer? This is CDC data from this year. Smoking still remains the leading cause of preventable death in our nation and in all the developed world. We lose about 500,000 people a year who die prematurely related to their smoking. On average, these people lose about a decade of life. And people think, well, we're doing great, smoking cessation is going to take care of it. But right now, the CDC says that today, children under 18, 5.6 million of them will die of smoking. So we still have a major problem. Now, this is a slide from the CDC. I've been showing it for a while, but it's important because people are constantly shocked to find out of all the smoking things out there, the thing that kills the most people is lung cancer. And it's about 50% more than heart disease in smokers. And this is a very important rationale for why early detection remains very, very important. It is not hopeless. It's far from hopeless, but we've got to understand the scorecard. This is, again, CDC data in which they're looking at tobacco control efforts over the last quarter of the century we just finished. And what you see there is through all the efforts from the Surgeon General's report on, we're able to save hundreds of thousands of lives in very, very significant ways with remarkably reduced healthcare costs. But as you see in the darker blue at the bottom, there's still a lot of work. Now, what I want to point out is that this axis still leaves 40,000 deaths per year of lung cancer, even if no one smoked. So this is a very important public health problem, and it's more than just smoking. Now, this is the slide from Pito and Dahl's work with the doctors study, where they looked at a cohort through a long time domain in England of physicians. And this is one of the poorest understood things in public health. And that is, when they follow these people, the continued smoking through the later decades of life is associated with just a stunning risk of premature death. However, if you stop at age 50, your risk of dying is still fivefold relative to the general population who never smoked. And if you stopped at age 30, your risk is still twice background, which is a big number. So that smoking is a remarkably long-lasting carcinogen. And so even after you stop, there's no break in the action at 15 years as suggested by the CMS data. It is a continuous relapse, and it's an important cause of death in this population until they are no longer on this planet. So why do we still have this problem? We still have this problem because the tobacco industry does spend billions of dollars a year. A lot of it in convenience stores, and a lot of it, the advertising is placed at 4 feet in height. So you don't see it, but kids do. And it's a remarkably pernicious industry, but it's still there. It results in $300 billion of economic loss. Half of that, more than half of that, is related to healthcare costs, which you're all intimately familiar with, but at least another, almost half of it's related to the loss of productivity. So people say, well, we tax cigarettes too much and we pay $1 to $2 of taxes every time somebody sells a pack of cigarettes. It costs the state of New York $10 in healthcare costs in aggregate. So we are subsidizing smoking because of our support of federal healthcare delivery. It's a remarkably pernicious industry. Okay, so again, it's not hopeless. This is from a PLOS publication from Bruce Pyensen's actuarial group from Millman here in the city. And they simulated using CMS data that over the next 15 years, if screening just did what screening can do from publications today, you can save close to 1 million adjusted life years with very conservative estimates, okay? And if you just took best practice smoking cessation as recommended today and offered that to all those at-risk individuals, you'd reduce the cost of that screening by close to 1/3 because of all the benefits of health care related to smoking cessation. So the two of these things working together are incredibly potentially powerful in shifting the cost curve and improving people's ability to have healthy lives. Now, what is happening? This is an American Cancer Society publication. It may be too early, but it's basically saying in 2015, which is the year following the recommendation for the national coverage decision to support the delivery of lung cancer screening in people who smoke more than 30 pack years over age 55, the NLST findings basically, they found that under 300,000 people had availed themselves to this screening service. Now, that study was very early, and they're not trying to be definitive, and these numbers are probably inaccurate, and they're changing, day by day, but it still gives you a sense that implementation of lung cancer screening is meeting with a certain amount of indifference or hostility in certain circles. And so the authors suggested, well, what we need to do is we need to educate clinicians and smokers, and we need to have a lot of discussion about how to do this and what the benefits are and what the harms are and whatnot. And so that's fine. And there's other perspectives. So the first thing is that lung cancer screening is hard to do. And so, if we go slowly on this and we learn to do it right, that's not a bad thing. And so, so we'll see how that happens. We got to remember, from the time the HIP study was done in this city demonstrating a benefit, a mortality reduction benefit of breast cancer screening, it was about 50 years before it was really accepted in our society. Colon cancer screening, which was, validated some time ago, is still struggling, and still, depending on who you're reading and what, it may be only 50% compliance with best practice recommendations for colon cancer screening. So we as a society don't really buy into these preventive measures. The worried well does fine, but the rest of the population, there's some challenges, okay? Now, there's concerns about medical radiation. There's concerns about false positivity. And there's also concerns that, we have about image quality. They just did a big VA pilot study for lung cancer screening. And it was, kind of a very difficult process. And when they did the audit after this study and they looked at images, they found that 40 to 45% of the images were technically inadequate for interpretation. That's kind of scary. So we have this challenge right now about how do we communicate this to the public? How do we communicate to this medical community? And so you can read here, there's a number of steps that have been stated. All of them, have some merit. And this is the other half of the recommendations. Well, it turns out we were just in Yokohama. We were talking about this in the World Lung Cancer Conference. And the screening people from Europe and other places were saying, wait a second. When we talk to people about screening, the more we talk about them, the more angry they get. We've just got to have simple messages. We've got to communicate in ways that they can understand. And then they say, okay, yes, will do it. No, I won't do it, but it's respectful conversation. We cannot force feed an enormous amount of information, much of which is flawed, in a context of very busy primary care settings. So it may be that we might just want to step back a little and just focus on the core elements of what screening is about. The medical radiation embedded in screening has changed, but even with the NLST, it was very, very low. And the projections now is with a conventional CT scan done in the community setting for lung cancer screening, the amount of medical radiation used with those, conservative types of approaches is not radically different than the radiation that somebody flying from California to Tokyo would receive. So it's quite a modest thing, and many public health groups are concerned that we're scaring the public because much of this has been overstated. That's not to say medical radiation in certain settings doesn't have incredibly important consequences, but the doses we're talking about here in a high-risk, chronically, 30-plus pack year population should not be the deal breaker in the screening setting. And there's other elements that are emerging. People don't understand. CMS is now paying $57 for the CPT code for a lung cancer, a low-dose CT scan technical component. It is one of the most inexpensive tests out there. But there are some important things that people have to understand, and that is only 1 in 100 people per year getting screened is going to have lung cancer. And some people will have to go back. But the test now that most expert screening centers do is a repeat $57 CT scan. It takes 3 seconds. It's not painful. No pressure on any part of the body. And so we've got to just decompress some of the angst about the delivery of this service. And we also have to have people understand that screening is complicated, and it really should be only done at institutions that are very committed to doing this correctly. Well, the other thing that's emerging is that if you screen 100 people for lung cancer, you find 25 people who have COPD. And the COPD you find is incredibly important. This is the second leading cause of tobacco-related death in our society. And the more evidence of parenchymal lung injury that you have, the more likely you are to die of it. And we've known for decades that COPD and lung cancer are comorbid. And we're not surprised because people have been smoking cigarettes and putting tobacco combustion products into their lungs at high doses for long periods of time. And so this is a very important finding. And this is a disease that we are just beginning to find therapeutic interventions that are important. Who saw the CHEST article last month that showed that people on statins had a 40% reduction of COPD-related death? Who saw the article 2 months before in Lancet that was previously published in JAMA, in which a pharmaceutical company, I won't go into specific names, Corey, a pharmaceutical company was developing a drug to reduce LDLs in high-risk cardiovascular populations, and it turned out that from a phase 3 study, long-term follow-up, there was a 40% reduction in lung cancer-related mortality. And there was a previous meta-analysis in the VAs in Puget Sound that showed that people on long-term steroids for COPD had a 40% reduction in lung cancer mortality. We're talking about drugs that affect the inflammatory responses of hosts, and they affect progression of lung cancer. We're going to be starting to look at this much more opportunistically, and so stay tuned. I understand there's some inflammatory component to lung cancer that people are excited about these days. So in addition, heart disease. If you screen 100 people for lung cancer, you find 1 lung cancer. You find 15, 20, 25 cases of coronary artery disease. And so again, this is reflected in the coronary calcium deposits they find in the bed of the coronary circulation. This is something that can be quantitated. This is from a study of 8,000 individuals, long-term follow-up from CT screening. This is reproducible. This has been published by the Nelson Group and others. And this is going to become an integral part of tobacco-related screening as we go forward because you're getting a much earlier window. These are asymptomatic people that were going in for lung cancer screening, and about 50% of them find out that they have significant coronary artery disease or significant COPD. What can we do about it? Turns out there's lots. So screening is a complex issue. It forces people who are asked to be screened to think about stuff they don't want to think about. They want to think about what the Rangers are doing or whatever is happening in their life. They don't want to think about the consequences of all the cigarettes they've smoked. It's an uncomfortable conversation, but it's going forward. We have tools such as what the American College of Radiology developed called LungRads, in which they have a relatively easy way to manage these nodules that are paralyzing certain individuals. And that's associated with somewhere between a 9 and 12% false positivity rate, which in the world of screening for any disease is eminently acceptable. We're starting to develop these quantitative tools for imaging that we can do an even better job. The group from ILCAP, the group from Nelson, that's the study in the Netherlands, the national study in the Netherlands. The group from the pilot study in the UK, when they use these volumetric techniques, their false positivity rate is 3%, which is remarkable. So we've been involved with this almost a little bit longer than this meeting with the Prevent Cancer Foundation, and we've been looking about how do we responsibly develop quantitative imaging. And we've done a variety of things. Workshops that we've done with the RSNA, Quantitative Imaging Biomarker Alliance, supported by the ISLC. We've worked with the people across town at Cornell and now it's Mount Sinai on developing image databases that we share with the rest of the world. There's been efforts for developing reference software tools, reference resources so that people can start aggregating and internationally collaborating in this regard. There's been a number of publications, most recent ones coming out in Cancer Research last month and in the British Journal of Radiology about the same time. I'll talk briefly about that. But there's a lot of people working together with the FDA, with NIST, to standardize these things. Now, why is this important? Because we can really work on the quality control, and we can take this terrible problem the VA has had with quality control, and we can reduce that through systematic quality control measures using state-of-the-art computational sciences. Now, we're doing this now with cloud-based automated analysis of imaging using reference objects. And this is being field tested right now nationally and internationally. and we're working with the FDA on these things. To use these cloud-based tools is remarkably inexpensive. These quality measures we're going to be able to do in the context of minutes, using techniques that'll basically say whether the scanners are working at a level or not to give us the precision to measure those nodules. So we're going to go forward. This is going to be screening for tobacco-related diseases. We're trying to do this in an ethical way. We're trying to do this in a rigorous way, supported with FDA type of measures for doing it correctly. It has to be integrated with tobacco control. And if we do it this way, we can bend cost curve. We can do it in populations in systematic ways in which there's evidence supporting the management. And it's going to be a process that continues to evolve because the technology in this regard is moving very quickly and in a very helpful way for finding ever earlier disease, so that we're going to have a vision of managing lung cancer the way we manage breast cancer. And I'll stop there. Thank you very much.